Hi, everybody. Welcome to our Occ-COVID this afternoon. We're just getting set up, and Kevin is the host, as you know, and he's just had a disappearing opening slide deck. So he's in search of it right now. We're very grateful that you're joining us this afternoon. We haven't had an Occ-COVID for a couple of months, but that doesn't mean that it hasn't been causing issues all over the province and all over the country and all over the world. And we're still committed to trying to find prevention strategies that can work for individuals and workplaces, and trying to share the knowledge that's been gained across the country, across the province. I'm just going to unlock the meeting so people aren't stuck in the lobby. I think we actually lost Kevin entirely. So, and we're getting an echo from someone else's. Oh, that could be you, Tony. So maybe Kashif, since you're here and you have a bit of a time crunch right now, maybe we'll start with you, and then we'll get Kevin to do some of his framing of what's been going on from an OHCOW perspective between you and Franz, if that's okay with everybody.
Thank you so much. Thanks for having me on. Great to be here again, and very nice to meet you guys again, and to meet the audience, and also to meet Franz. I've always admired from afar from all the work you've done. You're probably the only restaurant I'm going to eat in indoors, and I think we'll talk about more why. I'm just going to put up my slides quickly. So I'm going to share my screen. Can you guys see my screen?
Yep, it looks good.
Okay, so let's quickly introduce myself. I'm a medical graduate from University of Toronto, did my emergency and family medicine residency at McGill, did some international work overseas, worked pretty quietly in emergency medicine since then, trying to work in some startups, worked as a coroner where I see, where a lot of our worst cases end up. And I have ties to U of T and McMaster University. I was also, about this time 4 years ago, I saw some of the earliest cases of COVID in Canada at one of the teaching hospitals in Toronto. And I also was quarantined during SARS more than 20 years ago, 20 years ago actually, when that bug came and attacked us. So I was a bit traumatized then, and even more traumatized now, and that sort of informs why I try to keep on top of this, and inadvertently became a bit of a media person here for this issue. Helped co-found a group of great Canadians called Masks4Canada, where we, in the early part of the pandemic, got mask mandates, and I think contributed to prolonging the lives of thousands of people in Canada by bringing in a common sense public health measure at the most critical time of the pandemic. I'm just going to quickly talk about some of the medical advances, like some of the new discoveries made over COVID, its effect on the immune system, some bits on long COVID, ventilation, some approaches to mitigations you can do in your workplaces, and some recommendations. So some thoughts just working, over the last 4 years, like the issue why, we see such uneven measures, why there's such a political split over this. I feel like for a lot of people, it's not something that happens to everyone all at once. Some people die, are absolutely crippled. They disappear from public life, but the people who are unscathed are very visible, and you think that there's nothing wrong. Many have no ability to mitigate their workplaces, schools, or homes. If you send your kids to school and there's no precautions or any care about infection, you're at the mercy of that school or daycare. Some have worsening infections each time they get it. Some people barely know they've had it, even several times. And interestingly, I find with a lot of friends and colleagues, many don't know, and they don't want to know about what we're going to talk about. That is a understandable reflex when facing something that is without much precedent in our recent history and maybe in our longer term history. So a lot of us are not on the same page here, and how do we navigate that? That's a big question. Are we entering the age of the Infectocene? So you have all the different geologic ages and epochs. We had the Anthropocene, where we had the effects of humans on climate change, but are we entering a period where infection is dominating our daily lives in some way? This is a dashboard from one of the hospitals I work at. The light blue is beds occupied by respiratory beds occupied by COVID patients. As you can see, it never completely disappears. It comes in periodic waves almost 4 times throughout the year. And this is a pattern that we've seen consistently for the last couple of years in the post-Omicron era. COVID constantly is the top virus that we see in PCR sampling, in PCR samples that are taken across the province. The closest any virus came was influenza A about a month ago, but COVID is always the number one virus. We have not developed any immunity that could keep it at bay, and bring the numbers lower that we have for the other viruses, like the common seasonal coronaviruses, for instance. And the black line is most recent hospitalizations. We saw for most of the fall and the early part of winter, green is the baseline, and these are various, the other colors are 1 or 2 standard deviations above baseline. Admissions to hospital have been much higher in the last few months, despite widespread vaccination, despite widespread immunity from infection, that we're still seeing a higher baseline of admissions to hospital even after all this time. And this you can see even in children. Youngest children, our oldest and youngest patients. In the fall, we had way above, the green being the pre-pandemic baseline, way above that baseline we saw, and you could see it in the hospitals. We saw much more admissions amongst children, and we still see many more admissions amongst elderly, which is starting to drop off beyond the holiday period. And even now, if you look at federal government data, there's a constant strain on the healthcare systems across the country by a pool of patients who are needing admission and constantly need admission to hospital. And this is almost at some of the worst, a constant level that's about near some of the worst months of the pandemic in the active phase. But one good thing is the lesser ICU care, so that's one saving grace. Death counts are still quite high, nearly 2,000 a week in the United States at the beginning of January. We recorded 119 in Canada last week. So it's still a factor, and it's still far and above anything that you see with influenza, let's say. So what we do see now is there's more recognition in the scientific literature about the short and long-term effects of COVID, but it's uneven and not filtering through to regulators, through practice guidelines, and to frontline workers and to the general public. I frequently will see parents whose children have been diagnosed with COVID, whose doctors advise them not to get vaccinated, even though every bit of evidence shows that it is helpful and not harmful for young children. So let's talk about the immune system effects. So there's a collection of studies put together by my colleague, Dr. Lisa Yanatone, in which she examined this concept. Like, are we getting sick more now because we somehow didn't get sick in those 3 months or 4 months of lockdown, and that is causing an immunity debt? This is a collection of studies that show that COVID-19 is associated with a 40% higher risk of needing medical attention. So I'll tell you one thing. I have my caregiver's sick and my kiddo is sick, so I'm stuck home managing everything at home. This is the sign of our times, and you might see interruptions every now and then during this talk. So basically, 40% higher risk of needing medical attention in when there's RSV infection post-COVID-19, comparing the 2021 and 2022 seasons. There's also a greater risk of pneumococcal, bacterial pneumonia. And you can't say this is immunity debt because they measured 2 seasons for the RSV. And the rates of carriage, which people carry the bacteria, is unchanged. So there can't really be an immunity debt to this. Same thing with shingles. There is a 2.8 times higher risk of shingles after COVID. You can see this is your immunity theft right here in graph form. This is your immunity has been weakened, and your viruses that live inside you are coming out more because of that COVID infection. And I will often see strep, shingles, invasive strep, which is we're seeing in huge numbers in the last year after COVID waves. So all of these things we see much more often, and the data is finally showing that correlation. There's good explanations from the basic science, like parts of our immune system have been shown in studies going back this is from 2021, that the innate immunity is damaged for months after COVID infection. These are dendritic cells. These are part of the early part of your immune system that recognizes bugs that are about to infect you, and it fights them off without involving your antibodies. And then we have, T cell abnormalities, other immune system abnormalities that have long been documented but are being verified, especially in long COVID patients. And this is part of a talk I prepared with Dr. Leonardi, a PhD immunologist and a medical graduate, which you can find on YouTube. So the other thing with long COVID is that the mechanisms are gradually being better understood. Mitochondrial dysfunction and actual muscle damage from if you try to exercise through it because of the dysfunction. There's immune system alterations, there's T cell exhaustion, there's inflammation of the blood clotting system, there's a deregulation of it, there's complement activation, viral persistence. And the key thing is there's no reliable way to predict who gets it, when they get it. Is it after the first infection, after the fifth? How to prevent it and how to treat it. There's nothing available for that. And it has consequences. Like this is from a recent New York Times story in which there is widespread cognitive impairment that is increasing with time. So this is not nothing. Like there is definitely an effect happening. And what can we really offer patients who develop long-term symptoms? Not really a whole lot. It's often left to GPs to coordinate, many of them who are either unaware or have no idea what to do because there's not many guidelines. If you go through these different specialties, so cardiology, like people who get postural tachycardia syndrome or chest pain, most of the tests often will come back normal, and there is some recognition in their Canadian Cardiology Society about a pathway for that. For lung specialists, respirologists, there's some guidelines for post-ICU patients, but not much besides just monitoring and giving graduated exercises. For the neurologists, there isn't really anything they can offer for the brain fog many of us feel after infection. And they really can't do much until an actual stroke takes place. And then the hematologists, the blood specialists, they're mostly focused, their guidelines are focused on what to give someone when they're acutely ill in the hospital. This is one of the guidelines from the Canadian Journal of Cardiology and the Canadian Cardiology Society about what to do about when people get rapidly fluctuating heart rates and blood pressures, including doing the NASA 10-minute lean test as a diagnostic measure and other ways to try to discover causes. On the ventilation piece, a lot of new studies have come out. I'll just go over a few. This is a modeling exercise in which they found opening windows and HEPA filters reduced reduction in infectious particles by 5 to 7 times, combined with masks, 25 times reduction. This one was from Italy, which showed a 74 to 80% reduction in relative risk of infection in a classroom with better ventilation. This is an interesting one that came from UC San Diego, in which they compared 2 teaching hospital sites. The older hospital with poor ventilation and shared rooms had 4 times the infection as the newer hospital with single beds. And they actually found that more transmission took place when protocols were broken, like shared lunches in break rooms. They actually just used surgical masks. So source control with good ventilation really contained infection in this study. Regarding masks, we all know about the controversial Cochrane review, which has been denounced by Cochrane itself as not being able to conclude on this, but some new literature reviews have shown with observational studies that face mask use can reduce the spread of COVID-19. So I think what I would recommend is, set up your personal work life to minimize risk as much as possible, as sustainably as possible. I think, we can all go crazy thinking about COVID all the time. You can't eliminate all risk completely, but you can try to control the biggest risk points in your life. This was a neat diagram published recently in which it goes over the main methods, and a lot of these are doable. A lot of them may not be doable for everyone, but some things are better than nothing, basically. So in practice, what I do, we wear masks at work. It's not even required, but 95 to 100% of the staff at one of the hospitals I work at still wear it, even though it's not required. And I see 100 to 150 patients a week and have never gotten sick from them. There's good ventilation at the hospitals, upgraded after SARS. In clinics where I work, we've made sure to install HEPA filters. We measure out the output to make sure that it's sized for that room. And I'll mask in any crowded indoor space with a lot of people I don't know. So planes, Ubers, trains, buses, big box store with hardly anyone in it, probably not. With good CO2 rating, probably not. Maybe, and almost never outside unless it's a massive crowd, which I'll try to avoid anyway. Personal life, rather than restaurants, except for Franz's restaurant, I'll probably avoid, but rather host small groups at home. For kids, we set up play dates with family and friends, and we set up a rain date in advance. So if anyone has any symptoms, we just cancel and go to the next day. No shame, no guilt. We stay on top of boosters. We get antivirals if sick. We use grocery delivery, which saves a lot of time and exposure. These are just a bunch of rapid tests we did on some guests who visited the other day. It's not perfect by any means, but with a symptom screen, with people who are honest with you, and with this, it's just another thing that you can lower the risk and try to live as normally as possible. Steps that you can take. Check the ventilation quality in your workplace or school. You would be shocked by some of the things that people find in workplaces. Advocate for improvements as much as you can. During big waves, your company might be persuadable to try to become more mask friendly, more work from home to preserve staffing. That's a good directive that we sort of use in one of our hospitals, in that we said everyone wear a mask because we need to keep staffed up during Christmas, our busiest time, because a lot of people are getting sick and getting knocked out. In high-risk environments, masking, ventilation, and good sick time benefits are absolutely essential. This is an interesting paper that came out in SSRN, in which return to office mandates, in which companies that were doing it generally did not perform as well, or did it for dubious reasons to try to firm up stock returns, and were usually angry CEOs trying to prove something. So I think there is not a very strong case that return to office really enhances corporate performance. Quite the opposite. Just a personal example. So recently, we had one of our children got sick. We were able to do a rapid test. This is one we got from a supplier in Germany. It showed us that we had influenza A. The kiddo had influenza A. We quickly got some antivirals, took the prophylaxis dose, and the illness time was reduced just to 2 days. Whereas classmates in my kiddo's class were out for a week or longer because they didn't have access to antivirals for one of the few viruses that we do have antivirals for. So this kind of approach, goes beyond COVID. It can prevent other terrible illnesses as well. And, the fact is, something is wrong with the kind of advice that's going out there. This is from Dr. Berger, in which, we've spent 150 years improving the public health environment, clean water, antibiotics, modern medicine in general. And we've kind of thrown it to the wind with the idea that we can just wax and relax. If you feel something is wrong, that's because there is something wrong with the advice that we're getting right now. We are a social species. We find that the normal behavior of the tribe overpowers your personal desires. There was a social conformity experiment. There's a great thread by Lisa on this, in which 75% of people knew they were doing the wrong thing, but they did it because other people were doing it as well. So it's powerful psychology. But really have the courage to stand out if you can. You'd be surprised how many people will follow your lead. Never be afraid to address matters of your personal health and safety. So this is Brad Pitt just a few days ago, wearing a mask on set. He was the only one, but he does not care. He doesn't want to get sick. Well, I don't want to get sick. Be like Brad Pitt. Take a stand when you need to. This is a crowdsourced map we built with the assistance of the Balvi Foundation, in which we let people put out and log crowdsourced CO2 readings in buildings across the world. And yeah, we'd have a regular pool of users. It didn't become as widespread as I'd hoped, but we're still working on it. So it's something you can check out at ravenapp.org/cleanair. And this is what the numbers mean if you want to read up on CO2 levels, what it means inside a building, and what it means for its ventilation. So, we have the Heart and Stroke Foundation, we have the Canadian Cancer Society. These are the number 1 and 2 causes of death. But COVID, if you look at the numbers from last year, it's almost up there as the third cause of death. It kind of drops out. Trauma and accidents come as third sometimes, depending on how countries massage the stats. But it's really up there as a leading cause of death, number three or number four. And we need a society for this. And I'll tell you, I can't say anything yet, but we have an announcement hopefully soon about this, and we'll have something positive to say about this in the next few weeks. When I looked at a video with Bill Gates, an interview, what he thought the future threats of the world were climate change, bioterrorism, great power conflict, rapid tech change. When I saw this video, most of these hadn't happened, but all of them have happened in the last couple of years. We have great power conflict. We have rapid tech change with the AI revolution, bioterrorism. The possibility of the lab leak is becoming more realistic. Climate change. I've had many relatives affected by rapid climate events, including major blizzards and floods. So a lot of this stuff is happening at the same time, and COVID sort of contributes to it, causes it, and also just raises the overall fire. So it's something that we need to confront. But it's not something that we can do separately. It'll require a lot of work together to get to a common goal of mitigating and reducing the impact of this. And I think I think there was a thread in which you talked. What would it take to beat something like that? You need something like a Manhattan Project effort for improving ventilation indoors, getting better vaccines, getting better antivirals, getting better public awareness that they know to treat this when they get it. So that all of this will take effort, which sadly we're not seeing as much yet. Thank you very much, and we'll have hopefully a great discussion.
Thanks very much, Dr. Kashif Pirzada. We really appreciate you being here, and I just got to apologize to everybody else. I usually open the webinar, but I've had some technical problems myself. So thanks for Val for helping out there. I think what we decided was because you've got a hard stop at 2:30, so we thought we might just open the floor for questions before I introduce Franz, who's online. So Franz, who you can see, he's the restaurateur manager of Apricot Tree Cafe, and I can talk a bit more about Franz and his great contribution to clean air and being a great leader with all the work that he's done with his cafe. But before we go to Franz, I might go back to you, Kashif, and I just want to ask if there's anybody who has any questions to Dr. Pirzada. I guess I can start. The idea that reinfection increases our risk of long COVID. Some people have actually talked about the statistics and numbers of people with long COVID years down the track, with the rate of reinfection. I'm just wondering if you'd mind providing your comments on that, Kashif.
Yeah, I think the best study comes from Professor Ziad Al-Ali at Washington University, in which he uses the Veterans Administration, VA hospitals data set. And I think he's found really good cause to worry that subsequent infections can cause increase your risk of long COVID. And it just makes sense. If your risk is 3-5% each time, that just accumulates each time. I think it should be noted, like the risk is higher. I guess the same thing with the way COVID risk is higher if you're older, if you have comorbidity. So it seems whoever is at a higher risk of severe COVID is also probably at a higher risk of long COVID. And it seems to have especially higher risk for women, especially middle-aged or older women. So I definitely do see it. Like I see patients who had an uneventful first or second infection, and then the third or fourth one is the one where they start getting, that fog that won't go away or that cough that won't go away.
Thanks, Kashif. I'm just wondering, have you got any thoughts about the percentage of the population that might have symptoms of long COVID, a few years down the track? Have you kind of got an idea, a ballpark idea of how many people will be suffering from that?
It's hard to say because the definition is so broad, but I
Mm.
would say just from the patients that I see is about the risk is anywhere about 5% each time you get COVID, 5 to 10%. Um, so I would say maybe people who have all of the symptoms, including loss of smell, taste, brain fog, heart issues, lung issues, fatigue. I would say maybe 5 to 10% of the patients I see have some evidence of that.
Okay, thanks. I'm just looking at the chat box now, and those of us who've followed ASHRAE, and there's a new standard for infectious diseases, an ASHRAE standard for infectious diseases, ASHRAE 241. And I know, you've been following this evolution with the prevention, public health preventive measures as well, for sure, as well as being an emergency doctor and doing what you're doing. But what are your hopes for legislation to improve air to align with ASHRAE 241 in Ontario in all public spaces, schools, government buildings, etc.?
So
I just wonder if you.
what I've
So
seen,
there's a new standard, the new standard ASHRAE 241 for infectious. So it's improved ventilation for infectious diseases. But it's just, do you see that it's going to be adopted in legislation? Like, do you think that little things will move where workplaces will actually have to meet this new standard? I know it's a long-winded process, but I'm just wondering what your thoughts are on this.
I think quietly a lot of the big landlords have done it already. Like just looking at readings that people post on the clean air map. Even if you go to a mall, like I went to Eaton Center recently, and the CO2 was sub 500, which is almost like outdoor fresh air. So it's happening quietly. The key thing I think will be the schools. And so far, only the opposition in Ontario has proposed any legislation to require certain minimums in schools. But if that could happen. I know private schools in Ontario have great ventilation, but the public schools is an open question. That would be the key. That would really reduce a lot of transmission, especially in the winter months.
Okay. Somebody else, Vicky Roy, has posted in the chat box. Is there a significant difference in protection wearing an N95 mask on a plane or in a crowded indoor area as opposed to a surgical mask?
So I think overall you're much better off with an N95 mask in a crowded area, especially when it comes to the seal. Depends how the surgical mask fits on your face and the type of surgical mask. So there's a level 2 and a level 3 surgical mask. If your face is such that you don't have many gaps on the side, that's a great thing. But the N95s are much better because they provide a seal. Many of us in hospital have to get fit tested. Personally, when I'm going in a plane and it's a very crowded flight and I'm on boarding and deplaning when the air circulation is not moving, I want the best mask possible because I don't want to be sick on my vacation when I get there. So I wear the best possible one on a plane, and I don't care what people think.
Yeah, thanks, Kashif. I also have my Aranet on the airplane as well. So typically on the tarmac, the carbon dioxide levels will go really high. I've sort of read up to 3,000 parts per million just sitting there on the tarmac, and then the same the other side when, before a takeoff and then on landing, CO2 levels are extremely high. So to me, it's a really good indicator to wear a properly fitting respirator. But unfortunately, you look around the plane and there's not many people wear them now, and people are still getting infected. So hopefully, this might be a bit of impetus for people to think about those kind of things. Okay, so somebody published the link to ASHRAE 241. So of those of you who don't know it, just have a look at the chat box and you can actually go and look at the latest standard from ASHRAE. And Lynn, Dr. Lynn Filtrote, many physicians have not been leaders when it comes to COVID science. They have mostly deferred to public health. How do we get more physicians to use critical thinking around COVID-19 and follow the actual science?
That's a big challenge. I think overall we're all as physicians guilty of a lot of things, that the public is feeling too. Everyone wants this to be gone. No one wants to live in this kind of time. where you have to worry like this, and many don't, and they carry that with them. There's a lot of different political ideologies around this, and I think what I do is when I can approach a colleague when they've had, and I often cover for a lot of colleagues who are sick. I say, "How was it? How was your infection? What happened? How long were you sick for? Maybe you should think about getting the booster next time, or maybe we should start wearing masks more in the clinic or in the hospital." So I think I'm in a kind of a position where people come to me for advice because they know how up to date I am on a lot of the science. Then I just gently say, that illness didn't have to happen. It didn't have to be as severe as it was for you or your family member. Maybe think through what you're being told, and here's some resources that you can go through. So gradually, people are realizing things are not going as well as it should have. Like the last illness season, especially for children, was pretty awful. Like I, along with many others, had to wait in the hospital in the sick kids ER, waiting 10 hours. I think there's a public story on that right now. The fact is, it's just we haven't expanded the resources, and the demand is higher and there's a lot of people getting sick, and we can just try to explain and try to inform as best as we can, one at a time.
Thank you. So there's another question here. Thank you. How do you navigate healthcare for yourself and your family? And it's got, how did you get access to Tamiflu when you needed it?
So yeah, that was basically the child's pediatrician was able to prescribe it, and I had to make a case for it because there's a lot of we've never really been able to diagnose flu fast enough to prescribe it. The window is 48 hours for Tamiflu. For Paxlovid for COVID, it's 5 days. For remdesivir COVID, it's 7 days. So almost no one can get the medication in time to make it effective. But we knew because we had the flu rapid test. And I think this will be the way it should be done in the future, is that if you have sick kids, here's a test that can just test 5 things, and there might be treatments for them. So that should be a better future. Like we had such a much better course of disease than many of many of the other families in the class. Only as one of the kids had looks like a secondary ear infection after. So that happens after these infections, but. That's yeah, we were just lucky. Like we were able to reach them and get a prescription, get it filled, and then give it in time.
Can you just provide a bit more background on Tamiflu, what it is?
Tamiflu is an antiviral for influenza. So when people talk about the flu, it's often it's confused with the common cold. So common cold and flu are very different things. Common cold is runny nose and a mild itchy sore throat for 2-3 days, and you're better. Influenza is a deadly virus that can give you body aches, fatigue, breathing problems lasting a week or longer, and has killed 30 million people in 1919, and still continues to. Before COVID became a thing, the flu was the big bad virus to worry about, and an antiviral was developed, interestingly, based on a Chinese herb 20 years ago. The use of it is controversial because it's hard to get it early enough to be useful, and the studies on it haven't been that strong on either side. And now that it's generic, there probably won't be as many studies in the future.
Great, thanks. I see I can see your face, Val. Did you have a question or something to say?
Of course, I always have questions and something to say. Thanks, Kashif. I wanted to actually pick up on your comment. Well, I guess it's a compound comment around you having to pick up a lot of sick leave shifts from other peers or staff who are sick. And I guess just wondering more broadly about the impact on healthcare in real time and into the future. And I guess have you been able to be like, is there any point of influence there in terms of the organizations that you work with or where you actually work to be able to recognize the sick leave impact or the level of stress? So there's the demand, which is the patients coming in, but the actual experiential learning of the staff and how how sustainable is that, I guess. And then there's another piece to that, which has to do with transmission within the hospital, which is another issue. How many people are we actually infecting in the process of healthcare workers and other patients being sick and interacting? So big, long question about healthcare in general, I guess. Any other comments on?
So I think, yeah, definitely people are getting sick more often, but also people are staying home when they're sick now too.
It's good.
They won't come in and infect you, right, as much. And so that's those are two things. People are not going to be heroic and come in, very sick if they can avoid it. So that's a good thing, actually. Like before, the culture of medicine was just to power through and get through. I think there's just almost like a trauma response. No one really wants to talk about it. It's I think that's true for a lot of people in different places. Everyone knows that it's there. They know you know, but we just will not talk about it. You see patients with the strangest strokes and the weirdest clots and the weirdest vessels on your CTs and MRIs. You know what it is, and you can mention it as a contributing factor, but it's just not as talked about. So I think we need to get through that. Maybe, we need to have a conversation. Like, we went through such a traumatic experience with this. Life has changed. Our relatives are getting sick. We're getting sicker. We need to be open about talking about this, and how to do it without getting people to shut off, turn off, or groan, or not want to engage is a challenge. I don't know how to do it personally. One-on-one, I try to bring it up with people. I try to, and to the credit, almost all of my colleagues are wearing masks in the clinical setting, and they don't have to, and they do still because they know what's out there.
Well, that's good.
Thank-
I was just going to mention two things that I saw on, of course, Twitter this morning, that they've done a calculation in Germany about the 20 days of sick leave on average per worker or something like that recently, and they actually attributed that to the country's lack of to their GDP, basically, that their GDP was not in the positive, they were calculating in the sick leave impact. So I don't know when we'll get to that stage of doing calculations to recognize the impact on organizations and on the society at large.
So I
Thanks.
see Dr. Donald Cole, who he's an occupational physician with OHCOW. It's actually a pretty interesting question. I'm sure a lot of people will be interested in this. He asks, how about post-COVID rebound after using Paxlovid? Any suggestions for avoiding? My wife experienced, so I did not use it during my first COVID bout last fall.
This controversy about what the rebound is, like, is it the infection coming back, or is it the sort of the immune system reaction to your infection? No one really knows what to do. I'll just give you an example from my own family. So my in-laws, in Nova Scotia, one got sick with COVID, got Paxlovid through the health authority, which does the dispensing there, and got rebound. And then my mother-in-law was infected from the rebound somehow. It's not supposed to happen, but it did. So I think I don't know how to prevent it. There's no set way. It's kind of unknown what it is, but the theory is that it could be just your immune system reacting. But somehow, I saw an infection come from it. So it could be more than that. I think there's just not enough known about it. But if you're in a high-risk group that could progress to risk, that rebound you had could have been that wave of immune damage that could damage your lungs, that could have put you in hospital. So in a way, having a mild rebound after Paxlovid just reminds you that it's a good thing you took it in the first place if you're in that risk category.
Okay, thank you so much. And I see Lynn Filtrate, Dr. Lynn Filtrate's put a link in the chat box to some long COVID data. Did you want to talk to that, Lynn? If you don't mind.
I actually, the long COVID data is the StatsCan, and that's Dr. Mona Niemer help put out some of the statistics and showing that your risk with one infection, and I'm riffing, I don't know the exact number, but let's say it's 15%, then second infection, your risk of long COVID is 24, and then your third infection is 38%. And Gosha Gasparovich did a nice graph that if, you know, at this rate, you can actually map out how many infection you need before everybody's going to get long COVID. So it was, it's quite interesting that people still think, oh, I'm so young and healthy, I'm not going to get long COVID, or Omicron is mild. But the other article I put out is 10% of a healthcare worker in Quebec got long COVID, and the vast majority of them was during so-called mild Omicron, right? So there's a lot of myths out there that people think, oh, I'm healthy, I don't have risk factors, I'm not a woman, whatever, I'm not middle age, I'm not going to get long COVID. The reality is quite different. And as Kashif said, it may not be your first, it may not be your second, but it might well be your third. And we've seen that with athletes as well, that were so healthy and they got long COVID. The articles I put out was for Donald Cole, is that, you know, it's not proven, but the thing with the Paxlovid came out during Delta, and it came out with testing people that were not vaccinated. So we applied the data that we got out of those trials, the epic high risk, and we moved to, okay, now Omicron, now people vaccinated. So in reality, there's some among us that think that the 5-day of Paxlovid is not enough. So you're getting a rebound because if you take Paxlovid early enough, it suppresses viral replication. But then after 5 days, you stop, and lo and behold, the virus starts replicating. So it's a lot of people, not a lot of people, but there's a group of people that think the problem is the duration was based on Delta and not Omicron. And people now are advocating maybe it's 10 days that you need, or maybe it is 15 days. And sure enough, if you finish your Paxlovid and you still do a rapid test and you're positive, well, for sure, once you stop, it's gonna come back. So that's some of the reality. And the CDC did some research, and they seem to state that you can get rebound without even taking Paxlovid. So I don't think that if I could get my hand on Paxlovid, I think nowadays the reason to take Paxlovid for many people that are not in the extreme high risk is on the hope of preventing the post-COVID condition and the post-viral syndrome.
You know, I
And
think
that's where we need to do the studies, because we're in a different reality right now between infection, vaccination, and the data from the original studies is not applicable to the context, and severe outcome in 2024 needs to include what happens after 30 days. So long COVID, post-viral syndrome is a severe outcome. Your kid developing diabetes is a severe outcome, or you getting early heart attack or stroke or heart failure, etc., is a severe outcome. So it needs to be redefined, and we need to look at Paxlovid in that context.
Great information. Thanks, Lynn. So Richard Sutherland has posted, thank you for great information, Kashif. Can you recommend any good resources discussing immunity theft?
yeah, I posted the thread by Dr. Yanatone. It was masterful.
Okay.
It included a lot of the studies looking at RSV prevalence, strep, shingles. So I think overall, like, there is no way a brief lockdown 4 years ago is still causing problems now in terms of immunity debt. There's no way. Like, it's just beyond common sense now to understand that there's something else happening. And if you're a clinician, you see lots of patients, you see people getting shingles, you see people getting strep, you see people getting invasive strep in the months after. I'm waiting for it to happen right now after the wave we've just had. That we'll see another wave of this illness. You're already seeing media reports of people passing away from invasive strep again. So there's an effect there. Our decision makers can't deny it anymore. The evidence is there, as hard as a rock, basically.
Fabulous. Let's have a look. For rebound, one additional possibility is that 5 days is not long enough to be effective. The appropriate duration may be 10 days, and that's on the tail end of what Lynn said. And then there's some dialogue with Dr. Cole there as well.